Assalamualaikum, my name is Nur Shafiqah binti Karmani. Today I will be presenting about two articles regarding cerebral palsy management. This is the content that I will be explaining throughout my presentation later. The main purpose of this presentation is to critique and compare the better approach between two selected interventions in terms of motor learning for children who are having cerebral palsy problems. Before we go in depth into this presentation, let me explain first the definition of motor learning and cerebral palsy. Motor learning is a series or a set of internal process which associated with practice and experience. This requires a specific skill to produce a permanent changes on how the motor activity is induced.
While cerebral palsy is a collection of permanent but changeable of mobility, posture, and motor function disorder which is caused by a non-progressive interference, lesion, or malformation of the developing or immature brain. In this presentation, I will compare the two studies entitled A Motor Learning Intervention for a Child with Cerebral Palsy through a Social Assistive Robot by Butrego et al. 2019 and a study by Schnecker et al. 2018 entitled Home-Based Bimanual Training Based on Motor Learning Principle in Children with Unilateral Cerebral Palsy and Their Parents, the COAD study, Rationale and Protocol. The objective for the study by Butrego et al. Is to validate the effectiveness of physical therapy program to improve participation and fulfillment of therapeutic objectives for motor learning toward using a social assistive robot to increase child's number of steps without falling, while the objective from a study by Schnecker et al. Is to improve the bimanual skill of the child while minimizing the increase of therapy-related parental stress. From this objective, we can see that the outcome from this study will be different as the first study just measured the number of steps without falling, while the other study measured the bimanual skill of child, which covered the overall motor learning, not just walking alone. For the study design, the first study used single case study, which this provide a feasible alternative to large group of study as the subject used is only one subject. This design also involves repeated measure and manipulation of an independent variable, and it will be useful design if the researcher has limited resource, low incident, or to examine the expensive intervention. In these cases, this researcher used this design as this intervention using a humanoid robot, which is very expensive and have limited number of robots to be used in larger sample. Next, the second study used a protocol study design, which is a guideline in conducting a trial. This study is able to get the question to be researched and allow the researcher to plan and review the step of the project. This will produce a better research afterward if this protocol able to answer adequately the research question that has been set. The first study is held at the Physiotherapy Center, which concluded that the intervention is a center-based, while the second study held at the subject home, which means that it is a home-based intervention. The center-based setting will make the child unfamiliar with the environment and making them demotivated or afraid to doing the task given, while home-based setting, it makes the child feel safe in doing their tasks as they are already familiar with the environment, which makes them more compliant toward the intervention. For the participation, both studies did not mention about the exclusion criteria as the design used not required the researcher to do so. For the inclusion criteria, both studies choose younger age, while as it already proven that the therapy must be held at a younger age to optimize the therapy and develop maximum neuroplasticity and prevent further complication. This is by Kim et al. 2019. Study 1 used dyskinetic cerebral palsy as the type for the inclusion criteria. This type is the second most common after spastic type, while the second study used unilateral spastic type, which is the most common type in cerebral palsy with 77% of all cases. So it is relevant to do the intervention for this type of both type is the most common type for cerebral palsy. Both studies use gross motor function classification system and manual ability map classification system to classify the children. Lastly, the study will require the child to be able to interact with the environment and able to understand immediate contact, as the intervention needs the child to follow the instruction from the therapist and the robot. As for the procedure, study 1 used humanoid robot called Noah as the assistive robot in the intervention. This intervention consists of 16 sessions, 2 times per week and 45 minutes for each session. This intervention focused to motivate the child to walk without falling with the robot as an assistive device to make the child feel motivated to walk. The child required to bring the toy from the therapist to the robot. The starting position will be in sitting so that the child will do transition from sitting to standing and then walking afterward. The presence of the toy will make the child feel like this intervention more like playing field rather than rehab. After arrive at the robot, the child will touch the robot head and the robot will give a positive feedback to the child, which also can make the child feel more motivated to do the next task. This is because the child loves the attention and compliment, which will make them happy in doing the task. Then the child needs to bring back the toy to the therapist with the instruction from the robot. So, the function of the robot here is not for the mimicry purpose, but as a made for the child to be happy to walk and feel motivated to walk. This process will be repeated for 45 minutes. The repetition is needed in motor learning because it is important for the child to learn and remember the movement. The second study is a bimanual home-based intervention which consists of two approaches which are implicit motor learning and explicit motor learning. This intervention involves multidisciplinary team which will be coaching the parents so that the parent able to teach or train their child at home. This training needs to be completed in 12 weeks with average 30 minutes per day. This intervention is good because it involves the participation of the parent to train the child rather than just the therapist. This engagement will make the child feel appreciated and motivated to do the intervention. Plus, this intervention is being made at home, so the time will be flexible based on the child's mood. The approach is also good because it combines implicit motor learning which an unconscious learning of the movement and explicit motor learning which a conscious learning of the movement. This is because if the intervention only focuses on the explicit motor learning, it will make the parents feel stressed to train their child as the child needs to always be reminded and trained to use the affected side, while combining it with implicit motor learning will make the child to be motivated to keep practicing the movement as it happened unconsciously. So, the combination of these two approaches will be beneficial for both the child and parents. Both studies use SMART goals to set their goal of their intervention. SMART is stand for specific, measurable, achievable, relevant, and time-bound. This goal is to make sure that the objective of this intervention is achieved based on the time frame that has been set. This first study used goal-directed therapy as a parameter of their intervention. This parameter focuses on activity-based therapy, which the therapy is more to functional purpose rather than normal movement pattern, which can be seen in this intervention, which is walking. The result from this parameter will be beneficial for child to use in their daily living. To compare with the second study, they use goal-oriented 5 personal rehabilitation goal as their parameter. This parameter focuses on task-specific approach as this will make the activity become consistent with the context of goal that has been set. For the outcome measure, both studies use goal attainment scale (GAS) to measure the outcomes. This outcome measure is used to quantify and scale the objective of the study. It contains 5 items which scale from positive 2 to negative 2. The more positive the scale, the better the result. This scale allows to set individual objectives and it is sensitive to minimum changes, which is good to measure the progression of the outcomes. Only the second study have additional outcome measure, which is Canadian Occupational Performance Measure (COPM) to identify the rank child perceived problem in activities of self-care, play, and leisure. This is being made before the child undergoes their intervention as it made to measure the child ability. This outcome measure also has a good psychometric properties. For the result, first study showed that humanoid robot as an assistive device improve the child number of steps, which the GAS scale is positive 2. The positive 2 mean that the child able to walk 26 steps without falling. This result show that the study able to achieve the objective to make child able to walk more than 20 steps without falling in 8 weeks. Despite the child continuously improve their number of steps without falling, in the last session, which is 31 steps without falling. This shows that humanoid robot is good way to motivate the child motor learning and induce neuroplasticity in child. The second study proposed that bimanual motor learning with incorporation of implicit motor learning is able to reduce parental stress and improve therapy compliance because it can improve child's motivation during training. If the compliance improves, the result of intervention also will have a positive outcome as the child want to do the task repeatedly. For the study limitation, for the first study is the unclear causes of the improvement in the child number of steps. This is because it can be many possibilities that influence the improvement, such as thus the improvement is because of the motivation and persistence of the child due to the presence of human or robot, or to the methodology proposed and developed, or the critical moment of the child motor learning as child have been already been in rehab before. This study also did not mention specifically on how many times should the process be repeated in one session. It just provide the time frame, which is 45 minutes, without knowing how many attempts the child should do. Besides, because of this study is a single case study, we will not know how many of them beside this child that has been studied have a positive outcome from this intervention. Lastly, as the objective of this study has been achieved in 5 sessions, the objective is changed by researcher after the 5 sessions, but the problem is the task or environment is still the same without progression. So the result in this study will be questioned for this reason. For the second study, the only limitation that has been mentioned in this study is does not have an evidence-based practice yet, because this study is a protocol study. Because of that, the researcher need to do a further study to provide the outcome of this intervention. As for the conclusion, I'm choosing home-based manual training as the better approach in handling patients with cerebral palsy. Even it is a just protocol study, but previous studies have been proven that inducing implicit motor learning with explicit motor learning will be beneficial for the parents and the child. The setting of this study also play an important role toward the child compliance, as this study is being held at the home setting. The familiar environment makes the child feel more comfortable in doing tasks given. This intervention also good because it involves parents' participation, which will make the parents aware of their child's ability, and the parent will see the improvement of their child. The child also feel happy in doing the rehab, as she or he is doing it with someone that they are already familiar with. This intervention also practical and cost efficient, as the parent do not have to go to rehab center or use an expensive device such as robot or other to train their child, as therapists that planning the training will only use the tool that present in the house. In a nutshell, I'm choosing bimanual home-based training as a better approach in managing cerebral palsy patients. That's all from me. Thank you for lending your ear.